input, who you are, and what brought you to this webinar into the chat. We'd love to hear from everyone joining us. So just a little bit about our speakers. Dr. Cherie Livingston was born and raised in the inner city of Harrisburg, Pennsylvania. She always knew she wanted to become a physician and expressed particular interest in women's health at an early age. She started working as a candy striper at Community General Osteopathic Hospital at age 9. Dr. Livingston received a Bachelor of Science degree in biology from St. Joseph's University in Philadelphia, Pennsylvania. She received her medical degree from the Philadelphia College of Osteopathic Medicine. Dr. Livingston completed a rigorous obstetrics and gynecology residency at Penn State Hershey Medical Center in Hershey, PA. In 2006, she began practicing as an OBGYN at UPMC Lidditz. She is currently serving as the OBGYN department chair. She is a member of the UPMC Lidditz Board of Trustees. She is the highest volume female robotic surgeon in the county of Lancaster. Dr. Livingston is a founding board member of Patients Are Waiting, a nonprofit organization that is very dear to her. The mission of Patients Are Waiting is to eliminate health disparities by increasing diversity in medicine. Patients Are Waiting aims to increase the pipeline of minority clinicians, make the pipeline of minority clinicians less leaky, and support minority clinicians in practice. Dr. Livingston is a co-founder of the Diversifying Doulas Initiative, which aims to improve maternal outcomes through doula support. Dr. Livingston is a co-founder of Flow for the Love of Women. Flow aims to eliminate menstrual inequality, providing free menstrual hygiene products to vulnerable women and people in Harrisburg and surrounding areas. Dr. Livingston was elected to Governor Shapiro's Advisory Commission on Women. She's honored to be one of the founders and presidents of MOCA Moms, Moms of Kids Advancing, Mothers of Color in Medicine. Dr. Livingston gains all her pride and joy as the wife of Ivan Anderson, her childhood friend and neighbor. Together they are blessed to enjoy 2 daughters, Addison and Ansley, and twin boys, Ivan and Troy. We will also be joined by Ashley Hayward, who is a certified doula and breastfeeding specialist from Chesapeake, Virginia. Her journey to becoming a doula has by no means been linear. According to her resume, she has been a sales associate, credentialing assistant, customer success manager, and most often an actor. Whether she is helping a shopper find a perfect pair of shoes or offering an audience member a 2.5-hour escape during a play or musical, her heart is to serve. My heart for birth is to provide you with well-rounded information and a perspective that will empower you to make informed decisions about your birth. So thank you very much, and I will hand it over to Dr. Livingston now.
Anna, thank you for that wonderful introduction. It was warm and polite, and I appreciate being here tonight amongst colleagues, and I'm sure some folks out there I know. I'm totally excited to be here tonight. I'm a doctor who loves doulas. I just get right to the point, and I'm excited to have this dialogue with you tonight about something that's very near and dear to me. So I will start sharing my screen, and we will dig in. And Anna, okay, I think I have a little backup here so I can see that you all can see the screen here. So here are some objectives for tonight. We'll go over some statistics. We'll talk about causes for racial disparities, definitions of basic terminology. We'll increase, the goal for me is to increase the sensitivity and awareness around racial health care disparities. Although most of the folks on this call probably have a lot to teach me about many of these topics. And ultimately, we will understand the impact of the Diversifying Doulas Initiative. As my bio said, I was born and raised in the projects of Harrisburg, Pennsylvania, not too far from here. And one day I was sitting at the table at the age of 5. This story was told to me. Obviously, I do not recall it, but I was sitting at the kitchen table in one of those rooms right there in your backdrop, and I watched my um 80-year-old maternal great grandmother pass away in front of me. And as the family story has told, it was in that moment that I learned that I wanted to help people. I would always talk about helping people and making sure that all was well. And so I knew from a very early stage in my life that I wanted to help people, and I love math and science. You'll hear me talk about the Black Doctor Factory, which Dr. Hamblin and I have created here in Lancaster. And I want young learners to feel the excitement and the energy that I did as a young girl growing up in the projects about science and math. So before we get started, I want to level set here a little bit and talk to you about what some of the goals are tonight. The goal is to center birthing Black people. I say that without any hesitation in the world. And that's primarily because all birth is beautiful, but there is a significant disparity between birthing Black people and the rest of the birthing cohort. And although all moms are so wonderfully special, it's important that we center birthing Black people because uh, we must in with all of our heart, um, improve health disparities. Anna, can you confirm that you guys can still hear me?
Yes.
Okay, good. So before we go any further, let's talk about definitions. So pregnancy associated mortality and pregnancy related mortality. Pregnancy associated mortality is death while pregnant within 1 year, uh, irrespective of the cause of pregnancy. So an example of pregnancy associated mortality would be like a motor vehicle accident or drug overdose. Whereas pregnancy related mortality is something, it's a complication or death related to um, a physiologic event of pregnancy. And so the Maternal Mortality Review Committee examines all pregnancy associated mortality as well as all preventable pregnancy related mortality. And part of why the World Health Organization examines this ratio as opposed to a rate is because in the 184 countries where we look at maternal mortality, it's more logical to follow births as opposed to pregnancies because it's not easy to trace every pregnancy in a country, but there is some data supported way to follow and track births in a respective country. So the maternal mortality rate in the United States thus far outstrips that of other nations. So where do we rank globally? Last month, the CDC put out a report about the increasing maternal mortality rates in the United States since 2020. Remember, there is going to be a natural lag in statistics, and so right now, the data that we have in front of us is up to 2021, but most of us who are in the maternal mortality and morbidity realm are talking about data up to 2020 because that's what's most commonly reported. But the United States, of all high resource countries, sits at the top. This graph should stun everybody who is laying eyes on it. New Zealand, 1.7 deaths per 100,000 live births. The United States, as of 2020, 23.8. And our numbers have been increasing steadily. The United States and North Korea and Zimbabwe are one of the few countries with a rising maternal mortality rate since 1990. Of the 184 countries, the United States sits at 46 out of the 184. That's barely the first quartile, and that's unacceptable for the United States. And so What is it that we're concerned about? We're concerned about moms dying, but the Black mothers are dying at this disproportionate rate. Black mothers die at a rate of 55 per 100,000 live births. White mothers, 19. Hispanic mothers, 18. And it must also be noted that Hispanic women saw the largest maternal mortality increase of all racial demographic groups, rising by a staggering 44%. The United States maternal mortality rate continues to increase substantially. Unfortunately, this is not the first year that the United States maternal mortality rate has increased. We've been tracking this data since 2007, but only reporting it since 2018, and we've seen the numbers go from 17.4 per 100,000 to 23.8. Here in Pennsylvania, we took the time to review maternal deaths from 2013 to 2018, and 547 women died during this 5-year period. And during that time frame, 30% of those deaths were attributed to accidental poisoning. The drug overdose, unfortunately. So, drug overdose is the leading cause of pregnancy associated deaths in Pennsylvania and most other states in the United States. Of the pregnancy associated deaths with payment information, over 50% were paid by Medicaid. Nearly half of the women experienced pregnancy associated deaths did not receive adequate prenatal care. And we know that the American College of OBGYNs encourages birthing people to begin prenatal care as early as possible, but definitely within the first trimester, the first 0 to 14 weeks. Why do we care about this number? We call it the adequate prenatal care utilization index. We care about this number because mothers who do not receive prenatal care are 3 times more likely to have a low birth weight infant and 5 times more likely to have infants who die in the first year of life. Again, these are some statistics that the CDC gathered during that time frame. There was an increased trend in associated pregnancy-associated deaths, 84 in 2013, 102 in 2018. And the ethnic disparities, the racial disparities that stood out during that time frame and still are poignant to this day is Blacks accounted for 14% of the births during that time, yet we accounted for 23% of the deaths during that time frame. I don't know if everyone's heard of this video, and I don't think we have time to look at it, but I did put it up here. In 2021, the video Aftershock came out. Spike Lee's wife put out an excellent documentary about 2 Black women who died during the postpartum period. If you get a chance, you really want to look at this Aftershock documentary. It allows us to really level set and understand how the lives of Shamani Gibson and Amber Rose played such a crucial role in the movement to understanding and appreciating and centering Black birthing people. So, what's the reality? The reality is we can talk about statistics all day long, but the reality is systemic racism is the cause for health disparities. Black people aren't dying at the rate that we're dying because we're Black. It's because of systemic racism. It's baked into the system, and it's important that we unbake the cake. We dive into the whys. We must address social determinants of health, implicit bias. Everybody has bias, right? The bias is the brain shortcut. And so everybody has bias, but it's when that bias matriculates into a harm. And that's why it becomes something that we must address. Current inequities like COVID unearthed health disparities in like nobody's business. And it really showed the world healthcare disparities and widened those gaps. historical inequalities. Many of you out there have heard of Henrietta Lacks, the 30-year-old wonderful woman who lived a wonderful life in Baltimore, who died of cervical cancer, who died of untreated cervical cancer, so that her cells could be studied. The Tuskegee experiment that many people know and have heard about. So, the Health and Human Services put out this report that helped us to understand that there was a strategic approach to addressing social determinants of health. And I'll pause and let you really digest this picture. This is a pictorial representation of how we can address social determinants of health. And why do I make that a specific point? Because 20% of health outcomes are impacted by clinical care. So we doctors, the doctors on this call, the midwives, the nurses, the healthcare administrators, the doulas, uh, 20% of those healthcare outcomes are improved by what we do or harmed by what we do. But 50% of health outcomes are impacted by social determinants of health: housing, nutrition, transportation, the air people breathe, where they walk, or their lack of. Um,
Dr. Livingston, you cut out on the volume there. Stand by 1 minute. Dr. Livingston, can you hear me? Sorry, everybody. I'm sending her a message to try to.
is that better?
Yes.
Okay.
Apologies.
No
You
worries.
cut out about halfway through the social determinants of health slide.
Okay. Text me
I
if.
did text you.
Oh, did you?
I don't think it went through. Sorry.
No worries. Yeah. I keep okay, I see. Yeah, sorry everybody. I have this I am not certain what's going on with my Zoom, but I'll get us right back
I think we're all used to some difficulties with virtual.
with Zoom. Yeah. Yeah. Alrighty. So I'll go back to, yeah. So and I have my phone on so that I can look and see. Sorry about the technical difficulties. But yeah, I like I said, I love this slide because um it really puts it in perspective of how we can address the social determinants of health. We're able to look at it from a downstream, midstream, and upstream perspective. And regarding the upstream perspective, it's the whole of government. It's addressing structural determinants of health by imposing good policies and increasing access to affordable health care, and midstream, just addressing it from a community standpoint. And then from a downstream perspective, the doula client or doctor nurse and doctor-patient or nurse-patient relationship, that one-on-one healthcare that we can provide. But notice all throughout, we have addressing structural racism and enhancing data infrastructure as key components to maintaining the objectives and coming up with appropriate approaches to eliminating health disparities. So, what are some explanations of health disparities? Material, biologic. These things are normal, right? People live in different areas and have different realms of health and benefits. But again, there are some explanations that can be provided. What folks eat or their use of substances, occupation, what type of work they have, if they're exposed to discrimination on a daily basis. This stresses people, and that can actually cause aging and poor health. We talked about bias and what's the impact? The fear, lack of trust, lower self esteem, internalized racism. Well, we're here tonight to talk about solutions. Ashley Hayward and I are here to talk about what folks can do on an individual level, an organizational level, short term, long term solutions. So I'll move through a couple of slides so we can get to talking about the Diversifying Doula initiative. Anna, can you all still hear me? Are you still with me?
Yes, we're still with you.
Awesome. So, solutions from an individual standpoint, we need to stop blaming the victim, look them in the eyes. It's extremely hard to be mean to somebody if you're looking them in the eyes. It's sort of the normal human response to just empathize with people just by looking them in the eyes and listen without judgment and listen with empathy. And again, in order to have some long-term solutions, we have to measure what matters, diversify the perinatal workforce. And Dr. Hamblin and I have created the Black Doctor Factory. Why? Because since the 1960s, only 5% of surgeons and physicians in the United States identify as Black. And we know that studies show that if there is cultural congruence between healthcare provider and patient, they are more likely to adhere to preventive care recommendations, adhere to treatment protocols, and engage in healthcare research. So in 2020, Dr. Cherise Hamblin and I co-founded the Diversifying Doulas Initiative. As two Black OBGYNs here in Lancaster County, we said we did not want to see maternal mortality gaps widen. So we created the Diversifying Doula Initiative with the mission to improve maternal morbidity and mortality and decrease it by increasing the number of Black and brown doulas and providing fully subsidized doula care to birthing people of color here in Lancaster. And so what did we do? Lancaster County had one Black doula before DDI came along, and to date, we have trained 28 Black and brown doulas in Lancaster County who have, one is practicing in California. So all of our doulas are nationwide now and spread out, and we've provided over 250 fully subsidized doula care to birthing people of color here in Lancaster. So I think Ashley's on. So if Ashley's on, I'll pause so that she can talk about her experience with DDI, and then I'll talk about some research that we're doing.
Hi, everyone. Can you hear me? Can you see me? Good.
Yes.
We
Hi.
can hear you.
Oh, sorry. It was just been a little bit of a crazy day. I'm actually at a birth right now. I have a client laboring down the hall here. But yeah, so it's been a busy day, but I'm excited to hop on and just share a little bit. I'm one of my clients that I'm here with now. She actually is a DDI client, and when I first came to Lancaster, I had just finished my doula certification in 2020. And I started doing some research on places in the community that offer support for Black and Brown people in the county. And so I met with a good friend of Dr. Livingston's and a fellow doula. Her name is Rose Johnson Bundy. And she connected me to Dr. Livingston and told me about DDI and the work that they were doing. And I was eager to get started and to get on board. But just to show a little bit of comparison, I also have a private practice. And in 20, and out of all the births I had, maybe about 30 births this year thus far, only one of my clients through my private practice were of color. And so that just speaks to the fact that doula care is considered a luxury and not a necessity. And so most of the people that are willing or have the resources to financially pay for my services are white. And so I love the work that I get to do at DDI because I can prioritize getting the information, getting the care, and getting the education to the people that actually need it and are in desperate need of it. And so, and not to say that, you know, a white family doesn't need the care, but just making sure that we're able to, you know, even the scales a little bit when it comes to the success in birth. And so, yeah, I just really feel passionately about making sure that I'm supporting people that look like me. And I'm sure Dr. Livingston I'm sure she just shared a good amount of statistics with you, and you've seen the numbers of what that looks like. And so you can see why something like the Diversifying Doula Initiative is important. Excuse me. And there's one way I think that we can help, because I had just heard a statistic in my training the other day that about 90% of women or birthing people are going to give birth in the hospital. And so, what that tells me, in 100% of my births, I've been supported in the hospital. I haven't had any clients to give birth outside the hospital in my entire career as a doula. And so what that tells me is we have a unique job to not only educate birthing people on how to successfully give birth in the hospital system, but also as a doula to bridge the gap between a hospital staff and doulas. And so that's why I love the work that I get to do with Dr. Livingston and Dr. Hamlin, just to be a part of bridging that gap. And even when I'm at hospitals or various hospitals throughout the United States, or hospitals that are not where Dr. Livingston or Dr. Hamlin work, who are familiar with DDI, I really try to take initiative to introduce myself to whatever nurses I'm working with, introduce myself to the providers, to the midwives, and you'd be surprised at how the energy in the room can change when I just introduce myself and just let them know that I'm excited to be working together. I'm excited to work with you, get to know you, and see what we can do together to create a healthy birthing space for this client. And a lot of times that diffuses any kind of, you know, preconceived experiences, or you may see a doula walk in and be like, oh boy. And, you know, it's like, I'm here to work with you and not against you, because that doesn't serve either one of us. And it certainly doesn't serve my client here, so, or the patient. But I do think there are a couple things that we can glean from each other, right? And as the doula, I think, you know, providers and nurses can glean that I've been with this client, talking to them, walking with them, eating with them, conversing with them in their home since about 2 months after conception, or 3 months after conception, sometimes since conception. And I also will go home with them with their newborn, and I will be with them up to 90 days postpartum. And so I think I have just more time to understand how they understand information, how they prefer to be communicated with, how they actually retain information, because I've spent time asking them those things. Do you feel like, you know, what do you feel like is the best way to for someone to explain the next procedure or the next step in an induction. And we've taken time to go through each step by step by step to make sure they understand that. And I think at the same time, conversely, I think I know I am not a doctor. Okay, I am not a doctor. And so there, I always say, like, I can give you the information, I can tell you the evidence, but anything medical or diagnostic, that is not my that is not my lane. And so I think it's just a give and take of here's what I can do to support you. Here's what I can do to help you get to the finish line. Here's what I can help you do in post. But when the doctors and the nurses walk in the room, I'm going to step to the side, let them do what they need to do. And then we get back to work, And, when I'm at my home hospital, which is where Dr. Livingston is, UPMC Lidditz, it's a breeze, It's like a song and dance, and it's just really lovely. And I think all experiences in the hospital should go a little something like that, and just everyone working together to collaborate it. And so, but since that's not always the case, that brings us to what Dr. Livingston was getting ready to talk about, which is what do we do in the meantime, right? What do we do as we take those steps to work towards better and better service and more equality in hospital care. And so we came up with I don't know if there's I can't share my screen here. Dr. Let me see this.
Okay, yep, I'll pull it up.
Yeah.
The
Uh,
community doula education.
yes.
Yep, let
Yeah.
me pull that up.
Yeah. So we've been working hard and came up with me and a few other of the doulas that I work with came up with the idea of offering doula community classes in our area. And what those would look like is because a lot of us in the doulas I work with, we all have our private practices, but because we deal with a lot of Black and Brown clients in our area who can't necessarily afford doula service, what can we do to make sure that we can at least get them equipped to have a successful birthing and hospital experience? And so we sat down and came together and came up with the idea of offering doula community classes in the area. And what those would look like is just a series of classes, probably 5 or 6 classes. It's still kind of being workshopped, but a series of classes where we just cover kind of the basics or the overall view of childbirth education. And so what that would look like is it's free to our community, and we can make sure that free specifically towards Black and Brown people in our community, and making sure that they can attend those classes for free. And then doing what we can afterwards. If they're like, oh, I really love how Ashley taught, what do I need to do, or what steps can I take to get them to actually be my doula or with me during my birth? And then as the doulas, we'd offer some kind of personal discount or something like that, because at that point they already have the education. So a lot of the work that we would have to do privately is already done because they've taken all 5 of the classes. And so we could offer birthing support at the discount of our choice. And so just kind of brainstorming ideas to help stand in the gap, and I think, little by little, bit by bit, one client, one patient at a time, if we all just do our part and participate and listen and see and hear, I think we can actually make more forward movement than we might think.
Now you guys see why I'm a doctor who loves doulas. They are amazing. Ashley is amazing. Studies show that doulas spend 6 to 11 times more time with their they call them clients, we call them patients. It's all, it's all the same, but it's they spend more time with the patients, and that's producing so much better health outcomes. I mean, we have study after study. I mean, DDI has done 3 research projects now that we're hoping to publish. But one of the ones is our breastfeeding support initiative, where we took our doulas and yeah, I see some notes coming up in the chat. Actually, I can't wait. I know the chat is fire. I know it is so fire. But one of the research projects that we did, it was actually funded by Health and Human Services. We were one of 25 organizations across the nation that won a racial equity prize, and we took that money and did a breastfeeding support initiative. We use breastfeeding as sort of the catalyst to understanding and improving postpartum conditions like hypertension, diabetes, substance use, and postpartum depression. So we use breastfeeding as a tool to get to get into the um, to get to essentially survey the patient. So if you were, the 4 criteria were if you were Black, if you were breastfeeding, never had a doula throughout the current pregnancy, and had just delivered. We sent our doulas in prior to discharge, and they asked a 26 question survey questionnaire to really learn about any barriers to breastfeeding, what their thoughts and desires were regarding breastfeeding. We also asked them about diagnoses of preeclampsia and gestational diabetes and depression and substance use. And one of the main things that we received, one of the main pieces of information that we learned was 80% of the patients surveyed said that no one discussed postpartum depression or screened them for postpartum depression during their pregnancy. 80%. That's unacceptable. And this was a cohort of Black only uh, patients. And so I know here at UPMC, the providers found that information very valuable, eye-opening. They asked the question why. There's research out there that shows that when it comes to screening, people of color are not screened as often as their white counterparts. There's some qualitative analyses that that show and prove that Black patients, specifically Black postpartum patients, don't feel that they're being listened to or heard. And so that was a piece of data that stuck out. We also are doing another qualitative study where we're asking the question, is this culturally reflective care, where we have doulas of color taking care of clients of color? Is this culturally reflective care improving birthing experience for patients of color? And so we brought in an ethnographic researcher, and she spent hours with our clients, and we recorded their hour-long responses. Each of the clients sat down with the ethnographic researcher for 1 hour at a time, and the amount of data that we were able to elicit, the amount of qualitative information. We're combing through that data, looking to present that to the Health Equity Journal, and more to come on that. But you have to measure what matters. DDI can't walk around and just say, hey, what we're doing is great. We have to assess ourselves. We have to do program evaluation. So yeah, I think it's probably a good time. Anna, you can let me know if we want to entertain questions in the chat.
Absolutely. First, I'll just open it up to see if anyone has any questions before we head to the chat. Right. So I know there was some interest. Dr. Hartman, you commented about in the chat on New York State Medicaid covering doulas and hoping to provide more broader and equitable access to the doula care, and there's some interest in kind of hearing a little bit more information on that. So would you be able to expand on that? And I know Darcy also commented on that. So if either of you would like to kind of expand.
Yes, I saw that. Darcy, you can take it, I can take it. Go ahead and chime in since you're at DOH.
Actually, I'm with March of Dimes, and I'm part of the New York Coalition for Doula Access. The governor included reimbursement for doulas in her 2024 budget. The Department of Health has been holding monthly listening sessions with doulas from across the state. They've actually been very flexible and have modified the plan based on response from doulas. But currently, as it stands, it'll be $1,500 total for 4 prenatal labor and delivery and 4 postpartum visits in New York City, and then $1,350 for the rest of the state. Their plan is to submit the state plan amendment in December, and it'll go live 1/1/2024.
Yeah, you need to call your friends in Pennsylvania and tell them to catch up. We're doing good down here. We're trying. You know, the governor just signed the Senate bill to start tracking data on maternal morbidity. So, you know, we're making moves down here, but we want to be like New York.
Mario?
Hello, and thank you for an excellent presentation, and I appreciate Ashley's perspective. I have a comment in thinking about how to actualize some of the things that we've talked about, and one of the things that we're doing well in inpatient OB care is working as a team. You know, we know our colleagues, we know the nurses, we work together, we train together, we do drills together, we prepare for emergencies, we debrief, we discuss traumas, we support each other, and we don't have hospital-based doulas. And so when a doula is present, they seem sort of like an unconnected piece of a team. They're actually not part of the team. And I wonder if you have any, how are doulas like an Ashley in your practice or the DDI, how are they employed or not employed through the health system or a hospital? And is this a barrier that you've seen other places as well? Thanks.
Yeah, thanks, Mario, for that comment. And I think what makes DDI stand out, and I was told by the current president of DONA, what makes us stand out is we are a doctor-led organization that recognizes the importance of doula care, that recognizes that bringing them into the perinatal workforce is imperative if we want to improve maternal health outcomes in all birthing people. So the key is having not just doctors, but people who are walking within the walls of the hospital understand the value of doulas. And I'm not professing that there's some doula juice and that's the only thing out there is sprinkling doula fairy dust around and doulas are the only way to improve maternal health outcomes. It's not that, but it's the concept and the idea that understanding that is going to take more than just doctors, more than just hospital administrators to improve the health disparities that I talked about 45 minutes ago. We have to meet the people where they are. When we did the qualitative study here and we asked the patients about this cultural congruence and what they found so valuable in DDI, 91% of them said having a doula as part of my care made me want to do better throughout my pregnancy. It helped me understand, Dr. Livingston, some of the terms that you were using that in the little 15 minutes that we had together, it just wasn't settling in. So the solution is to understand that this is an imperative part of the perinatal workforce. And if doulas typically get paid through 4 pathways, through their own private practices, which I spoke at the Capitol about this. I have an issue with the fact that doulas have to do this as a side hustle. I'm a physician. I live here in this home. I don't have to be a doctor as a side hustle. So why do doulas have to do their wonderful work with all? I mean, look at Gruber's study in 2013. It showed decrease in low birth weight, decrease in C-sections, decrease in postpartum depression, decrease in increase in breastfeeding rates at time of discharge and at 4 weeks postpartum. The data is there. We continue to prove over and over that doulas are improving maternal health outcomes. So of the 4 pathways for payment for them, 1, their own private practices, 2, organizations like DDI, that's solely a grant-funded organization. We have to rely on receiving grants so that we can train doulas. The average cost of training our doulas is about $3,500. And that's because once you have the doula, the DDI stamp on it, we acknowledge that you've received mental health first aid, postpartum doula training, birth training, and CLC. You get your CLC. So and we have a DDI reader where there are certain articles that were like, you can't even let the phrase health disparities come out of your mouth if you haven't read, this article and looked at this chapter and have some non-clinical understanding of the pelvic anatomy. So by the time you walk out of our DDI program, led by 2 Black OBGYNs, you are ready to fight this health disparity battle. So that's number 2, having organizations like DDI. Okay, sorry about that. Having organizations like ours subsidize the doulas, and then Medicaid, number 3, and then number 4 is private insurances. If I long for the day where all insurers will say, we'll pay for a doula if the doctor says that it's clinically indicated and necessary. My dream is that one day, anybody who wants a doula should have a doula, specifically marginalized birthing people. Mario, I hope that answered your question.
So just to confirm, the hospital or the health system is not employing doulas.
No, not
Okay.
here. We are hospital agnostic. DDI runs on the volunteerism of 2 Black OBGYNs who happen to work for supporting organizations. UPMC supports us through various sponsorship. UPenn supports us as well, but we are hospital agnostic. So no, they are not employed by the hospital.
Scott, you have a question?
Yeah, I mean, it's more of a comment. Like, I think New York State should be applauded for its support of doula care through Medicaid. But also, I think you hinted on like doulas being compensated fairly. And some of the early Medicaid studies in New York State, like doulas were being paid very little. They were being paid like $500 per birth. They've increased that, but I think we'll need to see over time, is that really equitable, right? And there is a real push. We actually have this amazing private practice doula organization in Rochester, New York, that is all doulas of color, and they are a private practice, and they're really working to capitalize on this Medicaid compensation. But is it going to really be fair? So we need to see what's going to happen with that. But I think that we'll need physicians to really advocate very strongly in all states for doulas being compensated more fairly and more comprehensively because of the impacts on birth equity, as you mentioned. And then I just want to add on to that, lactation consultants or CLCs as well, like both doulas and people in lactation space, because people in lactation space have a huge impact on postpartum care. And so we really need to work for equitable compensation for lactation consultants and lactation coordinators and people in that space.
I agree 100%. When we worked on the HHS funded breastfeeding support initiative, we use breastfeeding as a tool to address many postpartum issues. I mean, 4 out of 5 deaths that occur in the postpartum period are preventable, and so that's where I mean, obviously we need to pay attention throughout the entire spectrum, but really emphasize postpartum care, because that's where many of our gaps exist, and that's where doulas can actually help significantly.
Thank you. Are there any other questions or comments? And thank you, Darcy, for putting some additional information in the chat around the New York Doula Access Program. I did want to just ask, because I know we didn't fully touch on this, but I was wondering if you could just explain what the kind of criteria is to qualify for the Diversifying Doulas program.
Yeah, so when we first started DDI in 2020, we sat down and we said we want to increase the number of Black and Brown doulas. We looked to our right, we looked to our left, and we were like, okay, well, let's provide free doula services to birthing people of color. And we realized that Lancaster had 1 Black doula, so we knew that part of our initiative was to train. And we paid for the cost to train wholly, because we didn't want finances to be a barrier. We sent out, so the way we did it is we had a website, and you could visit our website. On the website, we would say, are you interested in becoming a doula? And if you filled out that survey, then that queued into our doula navigator, and we had a DDI leadership team that reviewed all of the applications, and the applications were similar to a standard employment application. Demographics, of course. The most important question that we asked was, why do you want to become a doula? We ensured that we were clear that we were training a cohort of Black and Brown doulas. So we asked about primary language, preferred language, how do you identify yourself both racially and ethnically? And the question of why do you want to become a doula could become its own research project, because many of the doulas that came into the program had adverse birth experiences or knew someone with adverse birth experiences. And then other questions on the survey / application were, do you have reliable transportation? Because we need the doulas to be able to get to birth safely and on time. And then we also requested that they have a backup system, so that if a doula wasn't available, that she was able to rely on her backup to attend her birth. And then once we gathered a cohort, we would train cohorts of 10 each time, because it was easier for us to have a more one-on-one relationship with them. As OBGYN physicians, we really felt strongly about connecting with the doulas, and so even though we trained 28, we had cohorts of 10 and 10, 10, and 8, and throughout the 2020-2021 year. And we would then DDI leadership would go through those lists and just really make sure that we were bringing on people who were truly valuing what we as OBGYNs valued. And then we put them through a 16-week rigorous training program. It was online every Tuesday from 6 p.m. to 8 p.m. And we finished that 16 weeks of training, which 16 weeks of training is overboard. Like, even for DONA, they don't train that much. And for our lessons learned, like you may have seen up on my screen, DDI 2.0, when we go to train our second cohort in 2024, we've decided to cut that time frame in half from 16 weeks to 8 weeks. We were just starting, and so we really wanted to make a robust pilot program. But we'll train for 8 weeks, and they get their their birth certification. And we had a 2-day hands-on session here at UPMC Hospital and it was phenomenal. We flew in a DONA certified trainer to do hands-on training. So pretty rigorous, and we're proud of the model that we created. Our doulas, our certified doulas, get birth certification, CLC, mental health first aid, and I forget the fourth one, postpartum, birth certification, CLC, and mental health first aid.
Awesome. Thank you. I know, so Mario put in the chat about how we can work as the implicit network with DDI to review what we're doing with our fourth trimester model, which I'm not sure how knowledgeable you are around what we're doing, but we're kind of, the big things are increased screening. So doing a screening at 36-week prenatal appointment at hospital discharge, and bringing everybody in for an early postpartum visit within 21 days of giving birth, and screening there. So to identify risks sooner, and make sure our patients are connected with resources that they need, such as lactation services. And I think one of the big things within the implicit network is really wanting to partner with community organizations, and kind of how can the implicit network partner with DDI, and then also how can we use some of your lessons learned that you can kind of help steer us in, you know, some of the questions we're asking or how we're providing services.
Yeah, I think that it's it is astute when organizations with the same mission, goals, and objectives align and work together. I mean, a lot of the work is so duplicative, and it just seems like a waste of time and energy. So DDI would really like to look at how we can collaborate with implicit network. I mean, you said the key thing: resources. We are DDI and Patients Are Waiting values our model, which is to bring people in who look like the two leaders of the organization, train them up in all, with all due respect in using that phrase, and really eliminate barriers to their training. Take the cost away from them, create the framework, and then collaborate with organizations like yours to say, hey, here's this pocket of wonderful doulas that have gone through our training program. If you all have resources or pathways to use them at the 36-week mark, time of discharge, and then postpartum, then I think we plug and play and use them in that way. I don't think there's any really hard science here. I think it's just a matter of committing to working together.
Awesome. Thank you very much. Well, we will definitely, as a network, be reaching out. I know we've talked with Dr. Hamblin before, but I think really trying to figure out how we can build that partnership. Thank you very much, Dr. Livingston and Ashley. It was a wonderful presentation, and thank you on behalf of the Implicit Network and everyone who attended. We do have the